72-year-old gentleman with a prostate about 35 grams with an elevated bladder neck on cystoscopy. So the first thing I want to show is the actual implant, which is in a crimped form when we start. And then the next part is we're going to do the cystoscopy, and I'll show you the pertinent anatomy on the cystoscopy, and we'll talk about how this implant is placed. And then at this point, what we do is we remove the lens, and we will then essentially take the device, the implant, and then use the plastic sheath to support it in there. And gradually, we want to sort of try to see if we can get this blue marker that's on the implant at the 12 o'clock position, and then gradually advance the implant until you feel a release, which you know then that the implant is deployed. Anchoring leaflet, which is positioned just proximal to the verumentanum, and the lateral leaflets, which are the part that cause the pressure necrosis, at the 5, 7, and 12 o'clock position, kind of orienting and opening the prostate up with pressure necrosis. So at this point, the implantation essentially is complete, and what needs to be done is the cystoscope just needs to be withdrawn, and the bladder can be drained. And that basically completes the positioning of the implant. Turn my light on, and we're drawing the guide wire and removing it. So at this point, the only thing left in the patient is the suture itself, which then will be secured either to the penis or to the thigh, and the patient will be brought back in about 5 days for removal. We remove the sheath of the implant and then secure the string to either the patient's penis or the thigh, and then they leave that implant in for about 5 days, at which point they come into the office. You do need to use a special type of catheter, the barred catheter, which I will show you in the subsequent video when we do the removal. And generally in my practice, I send them home with a couple of days of Pyridium, antibiotics for a few days. In some situations, a short course of prednisone, if there's a significant amount of inflammation, can be helpful, but usually not required. The one one thing I tell patients is that if they develop symptoms of retention, which is very uncommon because the implant is holding open the prostate and it's very unlikely that they have retention, but if they do develop retention, they need to inform us because we need to have a special type of catheter that can be placed either adjacent or through the struts so it can get into the bladder and drain. Usually that has to be like a 12 French catheter or smaller. It's not likely that it's required, but that is something we verbally and communicate with the patient, and also send home in writing that if they end up in the emergency room for any reason, that the ER physician needs to contact us prior to placing any catheter.